Welcome back to another lecture from the Optum OCS prep course. My name is Jim Hefner. I'm a physical therapist in Boulder, Colorado, and I own a cash-based practice, Hefner Health. And in this video, we're going to be covering the shoulder girdle. So all things that pertain to the shoulder. We're going to get into that in just a moment. But first, I want to go over a case study to sort of prepare you for this lecture. We have a 64-year-old male who comes in with left shoulder pain. I want to know, what questions would you ask, and then what does your differential diagnosis look like? Well, first of all, I'm thinking a 64-year-old male. So I'm wondering if there's been any mechanism of injury or if this is a gradual onset of pain. I'm thinking of things such as, is this shoulder impingement? Is it rotator cuff tear? Could there be a labral tear? So I'm looking at, could it be a referred nerve thing from cervical radiculopathy? I'm looking at the regional joints and wondering what could be causing the pain. And then we'll use our movement assessment to determine if it's musculoskeletal or non-muscular. We'll use that and their subjective history to determine what's sort of the origin of the symptoms. So questions that I'm thinking about are past medical history. Is there anything that from the past history that could be related to the shoulder pain? Is there any sort of family history? Let's say he's a 64-year-old guy, so cardiovascular disease is the top sort of non-musculoskeletal thing that I'm thinking about. But so on the differential diagnosis list, there's a wide variety of potential diagnoses. The musculoskeletal stuff, and that's what we treat all day. So that's where we're thinking of our nerve, bone, soft tissue, all of muscular is at a muscle power deficit. But then there's the other, the systemic type things that we need to consider as well. If they are septic or if they have something like gout, or then we're going to be expecting there to be some sort of significant inflammation involved. If they have a rheumatological thing, that's going to come up on your subjective history, asking about past medical history. Things like gout is mainly in the big toe. It also impacts the knee, but the shoulder, I believe, is the third most common area that gets impacted. The same with Lyme disease. Lyme disease commonly causes achiness in the knees, but the shoulder is another common area. Avascular necrosis, it's less common in the shoulder, but it still occurs, so it needs to be on the potential diagnosis list. Things like cancer, they're probably going to have either, feeling unwell. They might be feeling feverish, weight loss, night sweats. So those sort of things are what we need to be thinking about if it's non-musculoskeletal. As I said on the previous slide, the first thing that I think of is a myocardial infarction, or an MI. That or an aortic aneurysm both refer to the left shoulder, potentially symptoms down the left arm as well. So when we're thinking about what is the potential diagnosis for someone who comes in with shoulder pain, asking questions around what started their pain, other health-related things is going to cue you into what's the origin of their symptoms. And figuring out the origin of the symptoms is most important because that's going to direct then what we do from a treatment standpoint. So the shoulder girdle is 15% of the OCS exam. And in this PowerPoint, I gathered information from current concepts, the CPRs, clinical prediction rules, the CPGs, which is the clinical practice guidelines, and then the Ortho Secrets book. And I recommend reviewing the clinical practice guideline for adhesive capsulitis in addition to this PowerPoint as well. So some of the objectives of the lecture today, I want you to understand the anatomy and biomechanics of the shoulder. That's going to be the huge bulk of the first section of the lecture. I want you to be able to explain the common pathologies, and we're going to get into that through a differential diagnosis and examination route. I want you to understand an appropriate plan of care for common shoulder pathologies and apply evidence-based interventions for common shoulder conditions, and then understand basic timelines and tissue healing for post-surgical protocols. There is some of that on the current concepts. You'll see how that varies based on quality of tissue, the individual person. So as we get into that, just take that, and just know that the surgeon's preference and the setting and everything is very important on surgical timelines. So the shoulder complex, there's 4 main joints, 17 muscles that just attach to the scapula alone, That's not even incorporating all the muscles that are in the thorax region that also could be contributing. But all of these need to act as one functional unit. So the four joints, we have the glenohumeral joint, the SC joint, the AC joint, and then the ST joint, which is the scapulothoracic joint. Those all need to be working together in proper arthrokinematics so that then the shoulder can function properly. The shoulder has a close relationship with the thoracic spine, the cervical spine, the rib cage, and even into the thoracolumbar junction. I often find myself focusing on core stability type of interventions for individuals with shoulder pain, because if you have strong shoulders but you have no base to support yourself from, then the muscles can't operate as efficiently. An example of that one functional unit of the shoulder is that during shoulder flexion, so as I raise my arm up, we need to have reciprocal thoracic extension occur, lifting of the rib cage. So we're going to see the first and second rib descend a little bit, fourth through sixth ribs ascend, thoracic extension, rib cage expansion, and then core stability. So if I arch back, but that's all coming from my spine, that's not true glenohumeral joint motion. So there's a lot of different areas that are working together, and we need to know what's working, what's not working, what muscles are strong and weak, or how is the body compensating to when we talk about shoulder rehab. Limitations in any of these structures can affect the movement of the shoulder girdle. A great quote about the shoulder that I like is that the balancing forces between mobility and stability in the shoulder complex is key to the efficient and effective management. As we get further into the anatomy, I'm going to talk about the force couple relationship between muscles, or how the dynamic stability around the shoulder and how the muscles need to support the soft tissue. The bony structure and alignment impacts how much movement can occur. So all of the forces that are going to determine the mobility and stability, and that's going to help guide you to whether or not the person is going to have a healthy shoulder. And that's speaking biomechanically. That goes a little different from a pain science standpoint, but these two things are so intertwined that they need to have good mobility and stability, and then they need to have, from a pain science standpoint, a strong understanding of pain and resilience in their body. So the bones of the shoulder girdle, we have humerus, clavicle, scapula. Those three bones make up four joints. The humerus is the long bone of the upper arm, articulating with the scapula proximally, and then the radial and ulna distally. It's the attachment sign of the rotator cuff, as well as many other prominent muscles of the upper extremity. And it has a close connection to the nerves of the brachial plexus, specifically the axial and radial nerves. So as we're talking about shoulder dislocations or shoulder instability, we need to be aware of what nerves are passing right around the humerus to make sure that those aren't getting impacted with an injury. The clavicle, it's an S-shaped long bone articulating with the sternum proximally or medially, and then laterally over on the scapula. So that's our SC and AC joints. It has four primary roles. It's a site of muscular attachment. It provides a barrier to protect underlying structures. So the brachial plexus, an important subclavian artery and vein, are right underneath the clavicle. It acts as a strut to stabilize the shoulder, and it prevents medial displacement when the muscles contract. So it acts as an muscle attachment site to provide stability for the chest area. And then it prevents inferior migration of the shoulder girdle. That I've had venous thoracic outlet syndrome on my right side, and I obviously have my collarbone, but they took out my first rib, and the first rib and the collarbone articulate together. So by removing the first rib, I notice more displacement of the clavicle. It still prevents some of the inferior migration, but I notice more play there. And that's an example of how the structures in the shoulder thoracic outlet area work together to provide a strong shoulder position. The scapula is the third bone here we're talking about. It's a free flowing bone that's held in place by muscles. So there's no bone to bone attachment. It's a flat bone that offers ample muscle attachment. As I said earlier, there's 17 muscles that attach to the scapula. It's made of cancellous bone, and that's important because it provides a ton of strength without adding much weight. So then the scapula can be very mobile without it being too heavy like the femur. It allows for greater degrees of freedom and provides a stable base from which the glenohumeral mobility can occur. Scapular positioning helps organize the glenohumeral muscles for efficient function. If someone comes in and their thoracic spine is in flexion, their shoulders are going to get pulled forward this way, and that creates a lot of tension through the pec muscles. It pulls the collarbone into an anteriorly rotated position, and that limits the ability for the arm to move the other way. And so as that happens, as the thoracic spine moves, the scapula tips into an anterior tilt, and also that's how all these muscles are connected. So we just talked about the three bones of the shoulder, and now I want to get into the musculature that overlays those bones. As we talk about the bones and we add the muscles and the other soft tissue in, then we'll get into how the joints function around all of that. But we're sort of adding layers to the shoulder girdle. So with the muscles of the shoulder, the first muscles that people think of are the rotator cuff muscles. And these are four muscles that help provide stability around the glenohumeral joint through force couples. And it aids in the motion of the glenohumeral joint. So I think about the rotator cuff as sort of this suction cup of four muscles that when we move our arm, the rotator cuff engages around the shoulder, and that allows for clean, smooth movement in the at the glenohumeral joint. These muscles are the subscapularis, supraspinatus, infraspinatus, and teres minor. On the picture on the left, you can see how the subscapularis lies on the inside surface of the scapula and then attaches over onto the humerus. And with the picture on the right, you can see the supraspinatus up top, the infraspinatus, and then the teres minor. Again, these muscles, they have a very short moment arm or a very short tendon, which means they're primary stabilizers. They help lock something into position so other muscles can work through movement. Now, the infraspinatus and teres minor, they have an effect for external rotation. The subscapularis is important for internal rotation, but there's going to be bigger muscles like your lats, your pecs, et cetera, that really help with that internal rotation too. So I think about the rotator cuff as this set of four muscles that is this primary stability right around the glenohumeral joint. And so this is one of the most common things that we see and treat in physical therapy. And the considerations that I think about with the rotator cuff are because the muscles run from the scapula over to the humerus, the position of this is going to be very important for the function of the rotator cuff. So if the scapula is really drawn anteriorly, the rotator cuff doesn't have a strong position of mechanical advantage to operate from. If I'm really squeezed back here and my elbows are driving that motion, then that's changing the orientation of the glenohumeral joint too. So to be able to use the rotator cuff sort of as a function of four muscles, a strong position on the glenohumeral joint is a good thing to have. One of the most common things that we see with a full thickness rotator cuff tear is that shrug of the shoulder as someone raises their arm up. There's not that depressing effect of the rotator cuff. So what we'll see is the whole shoulder rise up because of the superior pull of the deltoid, the assistance of the levator and the upper trap. So the rotator cuff, in addition to providing stability at the shoulder and aids in the motion of the glenohumeral joint, it allows for this depressing effect so it counteracts the superior pull of the deltoid muscle. These muscles come from C5, C6 of the cervical spine. So when someone comes in with a shoulder problem, we need to be tracing the muscles back to their innervation, and that's going to be through the brachial plexus into the cervical spine. So with the rotator cuff, we're talking primarily about C5, C6, but then all of the muscles of the shoulder girdle are C5, C6, and then into C7, C8. So if someone comes in with what looks like a muscle power deficit or a movement dysfunction type of problem, we need to be thinking about what muscles aren't working, but we also need to trace that back to a common nerve origin and make sure that nothing's happening at the cervical spine level that's impeding how well the muscle is getting its energy from the nervous system. You can look over this whole list here, But I want you to think of, and especially for the OCS exam, you need to know which muscles come from which nerve segments, because that's going to impact your plan of care. It's going to impact potential differential diagnoses. So next, we have the levator scapulae, which is we're going to go over a series of scapular muscles here. And the levator scapulae, it adducts, downwardly rotates, and elevates the scapula. What that means, so it adducts, so it brings the shoulder back in. It's what, if here's abduction, it adducts the shoulder, it downwardly rotates. So if this is my shoulder blades, it pulls them down together. And then it also, because of its orientation, has an elevating effect. It inserts at C1 to C4 transverse processes, and then it inserts at the superior scapular border. So you can see how when it contracts, it can impact downward rotation as well as elevation, which almost seem like contradictory motions. Through palpation, it's anterior and deep to the upper trap. So you need to go anterior to the upper trap and then deep down in there, knowing it runs from the superior spine of the scapula up to the C1, C4. These muscles, I don't think about these muscles as individual entities. I try to think about how they function as a unit. So the rhomboid, its adducts and downwardly rotates also. Because of its attachment, it doesn't have that same upward elevation of the scapula. It originates on the superior nuchal ligament and the spinous processes of C7 to T5. So it really lines that interscapular border. When you do rows and that sort of motion, it helps draw the shoulder blades back together. So having strong rhomboids is very important. Also having strong trap muscles is very important. And those need to be, if you're using your rhomboids on a exercise where the trap needs to help stabilize in a more neutral position, that could cause an injury or a problem, and the vice versa is the same. So these muscles are important at different times for different functional purposes. Next, what overlays the rhomboids and the levator is the trapezius muscle. So we have our upper trap, which we typically think about the person who's riding up like this. The upper trap functions in adduction, upward rotation, and elevation. So it's similar to the levator scapulae, except that the upper trap is an upward rotator. So that's important at the top for overhead elevation because it pulls that scapula into upward rotation. Whereas if someone's too rhomboid dominant, it's going to draw them into downward rotation of their scapula. The middle trap is a very important stabilizing muscle for the scapula. So if I'm going to do a pull-up type of movement, the ability to engage through my mid trap and low trap, that scapular retraction motion, is super important for helping stabilize the scapula in one position. Lower trap acts in scapular upward rotation and depression. So whereas the upper trap is elevation and upward rotation, the lower trap is depression and upward rotation. The upper trap and lower trap are one of those force couples that need to work synergistically to allow for smooth scapular movement. Oftentimes what we see is people are too dominant in their upper trap or they're too weak in their lower trap and middle trap. So as they go to do something, they don't either have the range of motion or the counterbalancing strength. So they end up with their shoulders at their ears, the inability to draw down and really brace that position. Here is going to be a stronger position for setting the shoulder blades. If I'm always up here, I can't use the rotator cuff, low trap and middle trap, serratus, and all of those muscles to help counterbalance that movement. Other scapular muscles, which we just mentioned, one of them is the serratus anterior. This is known as the boxer's muscle. It lines the rib cage and attaches on the inner undersurface of the costal aspect of the medial margin of the scapula. It's known as the boxer's muscle because when a boxer throws a punch, you could see that muscle run right along the rib cage there. And that action is what the function of the serratus is. So it helps with upward rotation and posteriorly tilting the scapula. So if I'm weak in it as I go, I'm going to drop that way. A strong serratus helps posteriorly tilt the scapula, and that keeps the glenohumeral joint open. If you're weak in the serratus, the opposite muscles to the serratus. So if my serratus tips back, the pec on the front side is the counterbalancing force to that. So if my pec minor and pec major are tight, I'm going to get drawn this way. And as I reach up overhead, if I can't tip back because the serratus is weak, that leads to shoulder impingement. It leads to compression of the rotator cuff. And what I have here is patients with shoulder with impingement have been shown to have decreased levels of serratus anterior activity. They have a delay in the firing of the middle and lower trap, and they often have a dominance of the upper trap and levator. And that matches what we're talking about, these dynamic force couples that need to work together. If your serratus can't help set the position, then your middle and lower trap can't be as effective in stabilizing the position either. We've mentioned some of these force couples already, but that's the synergistic coordination of the different various muscles throughout the body, but it's the shoulder girdle for this lecture. Examples are that deltoid rotator cuff. Those need to work. And as we get into scapular humeral rhythm in just a minute, you're going to see more about that one. The lower trap, upper trap, and serratus, as we had just mentioned. And then also the balancing effect of the anterior versus posterior rotator cuff. Anterior being the subscapularis, posterior being the supraspinatus, infraspinatus, and teres minor. The thing that you should think about is that every muscle has a counterbalancing muscle. So posturally, if I'm really drawn forward or really internally rotated, that pulls the muscles in one direction and then it pulls from the muscles on the opposite side. If I'm really internally rotated, that's taking all my internal rotators into a short position, including the subscapularis, but it's putting a length across the scapula to the glenohumeral joint. So then those muscles are having to work harder, and that's an imbalance in the shoulder, and imbalances in the body. Lack of balance is a lack of homeostasis. That's a lack of the ability of the tissues to respond, and that becomes a problem. Okay, so now we're going to get into some of the joints in the soft tissue. So we've covered the bones, we've covered the muscles, and this is sort of what brings it all together. These are just two picture examples. On the left, you can clearly see an anterior dislocation of the SC joint, or at least a subluxation there. And then on the picture on the right is a AC joint, sprain or dislocation, separation, shoulder separation. The glenohumeral joint, the head of the glenohumeral joint is 3 to 4 times larger than the glenoid fossa. And so what that means is that you have this really large head fitting on a smaller surface of the glenoid. And that is good in many ways because that's going to allow for a lot of movement across this joint. And that's why the glenohumeral joint is the most mobile joint in the entire body. The humeral head, so if this is the glenoid, here's the humeral head. It faces, if you're doing this on yourself, it faces medially, posterior back this way, and slightly superior. And then that's going to be offset by the position of the glenoid, which gives it somewhat of a bony stability position. But at the glenohumeral joint, don't rely on pure bony stability for much support. We're going to use our labrum, our capsule, the rotator cuff. All of that is really where its stability comes from. Other important members, there's an angle of inclination of 130 degrees and then humeral retroversion of 30 degrees. You can see what that humeral retroversion means is because of how the humeral head sits slightly forward, that creates this angle of retroversion at the shoulder. But the angle of retroversion and the angle of inclination, they're confusing topics because of how we have to think about it three-dimensionally. From this picture here, you can really see too how the position of the thoracic spine and the rib cage will really impact how the scapula can set and the scapular angle, and for that matter, the clavicular angle. So if I slouch, that clavicular angle narrows. It's going to put a greater than 35-degree angle on the scapula. And the take-home point of that is the structure and position of one area directly impacts the structure and the function of other areas. So as I mentioned, we have a little bit of bony stability throughout the glenohumeral joint, but there's also all these other passive stabilizers that help. So the muscles are going to be our active dynamic stabilizers. All of these other structures here are what brings passive stability to the shoulder. That is the glenoid labrum, which is, as you can see in the picture, this thin lining of tissue that runs around the shoulder. We'll get a better picture of this from a side view in just a moment. Other things that bring stability are going to be, there's limited joint volume or joint space there, so that helps with some stability. There's the natural intra-articular pressure or intra-joint pressure helps create stability. And then the capsulo-ligamentous structures, so our inferior, middle, and superior glenohumeral ligaments, other ligaments around the area that attach from the glenohumeral joint up to the acromion. So there's a lot of these passive stabilizers, which are extremely important. As I was mentioning, going from, well, let's take a step back for just 1 second. So here on the front side, you can see this is the front side of the shoulder girdle because there's the subscapularis. On the back side, this is going to be teres minor, infraspinatus, supraspinatus up here. So superior, inferior, anterior, and posterior sides. With the glenoid labrum, well, let's go from the inside out actually first. We have our glenoid fossa, so that's that small surface that accepts the area of the humeral head. And then working out, here's our glenoid labrum. So that's this thin layer of tissue that comes up there and then turns into or attaches with the bicep tendon. And that's why when someone has a bicep tendon injury, we often need to worry about slap tears or some sort of labral tear with that. Glenoid, labrum, and then the next outer layer is going to be our glenohumeral capsule. And so that's this other sort of redundant soft tissue that it allows for stability and it allows the humeral head to move more while still maintaining stability. So that's sort of how, if you look at the structures from the inside out, we have the bony glenoid fossa, the glenohumeral labrum, which attaches and becomes the bicep tendon. And then we have this large capsular tissue around it, with which then on top of that is the rotator cuff, and then even beyond deltoid and the bigger muscles. The glenohumeral capsule. So here we just talked about that capsule, that outer lining beyond the labrum. The capsule alone provides little support without other dynamic or static function. But the capsular strength has an inverse relationship with someone's age. So naturally, our soft tissue becomes more frail as we age. This is collagen, it's connective tissue, and that connective tissue dehydrates somewhat and loses elasticity with aging. And that's a consideration we need to think about, probably why you don't see a ton of young people with adhesive capsulitis either. The capsule is important because adhesive capsulitis or frozen shoulder is a fairly common thing that we see in orthopedic practice. When someone comes in and they have a capsular pattern, that means that shoulder external rotation is the most limited motion, followed by shoulder abduction, and then shoulder internal rotation. And when they come in and they match that capsular pattern, it tells us that of all the structures, that is a tight capsule, and that is what we need to work on, getting more mobility in that capsule area. And I would think about that as it's a soft tissue that doesn't have a ton of blood supply to it directly. So we need to work on getting movement, oxygen, blood flow into that area through regular sort of up to the point of pain range. So the capsule is very important because we see quite a few people with adhesive capsulitis. Other static or passive stabilizers of the shoulder are going to be our glenohumeral ligaments. So that's our superior, middle, and glenohumeral ligaments, as well as our coracohumeral ligament. The coracohumeral ligament isn't, there's no wording connected to it here, but it's this one that provides some superior support or restraint of the glenohumeral ligament, of the glenohumeral joint. The superior glenohumeral ligament provides some stability and support to the bicep tendon, and it also helps provide restraint to inferior restraint when the arm is adducted. So because of its orientation, think about it, if the arm is getting pulled inferiorly in adduction, that is going to get put on some tension. And that's a good thing. We want this restraint to check the motion. The middle and inferior glenohumeral ligament limit external rotation. And the inferior glenohumeral ligament is the strongest and most important, you could say, of all of the glenohumeral ligaments, because that's the one that really provides support against anterior inferior dislocations of the shoulder. That typically happens in a position of abduction. So as I go into abduction and external rotation, the middle and inferior glenohumeral ligament provide restraint and support against that. And so these are very important muscles for stability, passive stability of the glenohumeral joint. In addition to these ligaments here, you can also see the corticoclavicular ligaments, so the conoid and the trapezoid, and then also the coracoacromial ligament. And we'll get into those a little bit more soon. But next, let's talk about the sternoclavicular joint. So the SC joint is the joint that comes together between your clavicle and your sternum. And it's a saddle-shaped diarthrodial joint. And because of that joint orientation, there's large amounts of mobility that exists. So from this joint alone, we get 30 to 40 degrees of elevation and depression. So if I drop my arm down or if I raise my arm up, we're going to see movement occur there. It needs to have a rotational component that works with the AC joint. So as I raise my arm overhead, there's going to be this posterior rotation that occurs at the SC joint. And then also protraction and retraction. So as the arms reach out away from the body, the shoulder needs to protract, and then it needs to go back into retraction there at the joint for those movements. So it works in all three planes of motion. Unique to the SC joint is the fact that it is the only true skeletal articulation between the axial and appendicular skeletons. What that means is what really holds the whole position of the glenohumeral, the shoulder complex, is this SC joint. And that's why all the muscular support and soft tissue support is really important. But I mean, this is everything's give and take. We don't need as much bony stability here because the function of the shoulder girdle and the glenohumeral joint is going to be much different than, let's say, what happens at the hip joint. So the SC joint has a capsule around the entire joint that's relatively weak. So we don't get as much capsular stability at the SC joint. And we have anterior and posterior SC ligaments. Let's see, here we have the anterior SC ligament, and then we can't see the posterior SC ligament because of its orientation. But if you think about how ligaments need to check the movement of something, the posterior SC ligament is thought to be the most important one, because when you have an SC joint dislocation, it's going to happen anteriorly, like as we saw in that very first picture. And that's important because if the SC joint would get dislocated posteriorly, there's some very important structures, arteries, veins, and nerves that underlie that area. So we need that posterior SC ligament to be very strong to resist the movement of any motion posteriorly at the SC joint. And then we also have an interclavicular ligament that spans both medial ends of the clavicle. So over the top of the anterior SC ligament, we have this interclavicular ligament that runs across there. You can see that the SC joint, because it's a synovial joint, it has an articular disc in the middle, and that acts as some shock absorption. And then you can also see, as I was saying with my thoracic outlet syndrome case here, where they took out my first rib, you can really see the close connection of the clavicle with the cartilage in the first rib here. So if you remove the first rib, that's going to have impact on what happens, there's probably going to be more than enough available movement at the sternal end of the clavicle then. SC joint here, as we work our way out on the clavicle, we get to the AC joint, and that's the articulation between the acromion process. So we have our acromion process here, and then the distal end of the clavicle. So as the distal end comes over, it matches the acromion on the scapula. It's a synovial joint with mobility in 3 planes of motion. Similar to the SC joint, which has 30 to 40 degrees of elevation, that AC joint also gives 30 degrees of elevation and depression. It has a rotational component to it. So as I go back into abduction and external rotation, the AC joint needs to be able to move in a rotary component. And then it also has to work with protraction and retraction. We know a lot of times people with AC joint dysfunction doing a horizontal adduction becomes very painful at the shoulder, and that's because of inflammation, scarring, etc. That protraction and retraction motion gets disrupted when the AC joint gets disrupted. This joint relies on ligamentous stability for support. There is superior and inferior AC ligaments, and there's also the corticoclavicular ligaments, which are very important. Those corticoclavicular ligaments are the conoid and the trapezoid ligament. So here you can see the more medial one is the conoid ligament, and that resists clavicular elevation and protraction. The trapezoid assists in AC joint compression, so maintaining stability at the AC joint. The more important thing to think about is this runs from the coracoid process, so it runs from the scapula onto the clavicle. So it provides restraint between those two movements. So it helps keep those bones in a good alignment. And then next we have our scapulothoracic joint, so the ST joint. This is a physiological articulation because, as I said at the beginning, there's no direct bony attachment point of it. So no bone-to-bone connection. Its active range of motion is upward rotation of 60 degrees. It needs to be able to posteriorly tilt as the function of the serratus anterior. And then it also needs to be able to externally rotate 15 to 25 degrees. And so as one raises the arm overhead, it upwardly rotates, posteriorly tilts, and then it kind of opens up into external rotation too. Internal rotation would be the position where as the scapula like rounds in that way. So these are combined movements, so you get scapular abduction, but internal rotation. External rotation is the opposite. As I raise up overhead, the scapula opens to help set the position of the shoulder. Scapulohumeral rhythm, it's a very debated topic in orthopedic medicine. Is it important or is it not? Because we see a ton of scapular dyskinesia without people having pain. I'm on the camp that biomechanics matter in a different way than pain science matters. So I think one's scapular rhythm is very important. That goes back to some of my biases from having had thoracic outlet syndrome. I felt when those muscles were really weak, my ability to stabilize my shoulder complex was very weak. So once the muscles got stronger and the control and rhythm of those worked better for active range of motion, I felt a lot stronger in my shoulder. With scapulohumeral rhythm, there's going to be a 2-to-1 motion. So for every degree of movement that happens at the scapula, there's 2 degrees that happen at the glenohumeral joint. As I raise my arm all the way up overhead, the scapula moves 60 degrees into upward rotation ideally. So you'll feel that as the inferior angle comes across the side, but that aids with 60 degrees. And then the other 120 comes from the humerus. And that's where you get that composite 180 degrees of motion. If my arm was fixed at my side, I could only get to about 120 degrees here. As I let that go, then I can get a lot more movement there. The deltoid and the supraspinatus initiate abduction. So when the arm first goes into movement, the deltoid works with a force couple with the supraspinatus to lock into position to help with that movement. The serratus anterior sucks the scapula against the thorax. So as the rotator cuff engages here, the serratus anterior helps pull that back along the thorax. 0 to 45 degrees is pure glenohumeral joint motion. So there's not a ton happening at the scapula. After this 45 degrees, the humerus starts to slide inferiorly as the scapula begins to do its motion. At 75 degrees, we're going to see this humeral external rotation. So at about this point here, not quite 90, the humerus needs to start turning a bit. And that's why when the thumb is open, external rotation, it's generally a more available pain-free movement. If my hand is down, so internally rotated, I'm blocking that, and I can feel more of an impingement in the shoulder. Here opens up the movement and allows for full motion. At 110 degrees, corticoclavicular ligaments tighten. Those are the ones that they tighten to help provide restraint and to keep too much mobility from happening. All right, so that was the overview of all the anatomy and the joints. Now we're going to get into how to evaluate and examine the shoulder. Something I want you to think about from a plan of care standpoint, from a overall professional standpoint of how we're treating people. Only 50% of all new patients of shoulder pain presenting in primary care show recovery by 6 months. And about half of all patients with shoulder pain and dysfunction continue to experience symptoms for a year to a year and a half after diagnoses. That tells me that we're not doing a very good job. And uh, and I think if we start educating people better about how to strengthen the shoulder and how the position of the shoulder matters and how to understand pain, all of those things are going to lead to better outcomes. This comes from the clinical practice guideline on adhesive capsulitis. And this is going to be our basic level 1, 2, and 3 about how to treat someone who comes in with shoulder pain. So someone comes in with shoulder symptoms. At first, we need to do a level 1, and this works for the shoulder, but this is kind of how I think about treating all joints in the body. That level 1 screening is going to be our history. It's going to be our basic exam, our red and yellow flags, and that helps us determine, are they not appropriate for PT? Let's say they have something non-musculoskeletal, some heart-related thing going on, or are they appropriate are they appropriate, but they might need a referral back? Assuming they pass this level 1 screening, then we can get into our pathoanatomic diagnosis, meaning that they're from here, we have to determine, is it the shoulder that's the origin of symptoms or a non-shoulder origin of symptoms? Non-shoulder origin of symptoms could be like if it's cervical radiculopathy. So they're still having something that we can treat, but it's just not coming from the shoulder. Shoulder origin of symptoms is going to be something such as a rotator cuff dysfunction. So it's a muscle power problem. It could be adhesive capsulitis. So it's a tissue extensibility problem. It could be a glenohumeral instability. There's too much motion in the shoulder, or it can be in this sort of bucket of other things. It could be a kind of a mixed classification of those. After we do this line of, we're figuring out what's the origin of symptoms, then we need to get into our rehab classification, which is how irritable is this person coming in with? And that's going to help direct what interventions we do. We look at that as highly irritable, moderate irritability, or low irritability. So let's see what we're going to go back to this level 2 classification here. So level 2 is figuring out the origin of symptoms. From our specific exam, we're going to see if it's a mobility deficit. These are not in the same order as the prior one. So if it's a mobility deficit, meaning is it something adhesive capsulitis related, or is it more tissue extensibility? Is it instability related, rotator cuff dysfunction, so a muscle power deficit, or other? Those same 4 categories. What we can expect from each of these is if the person's having mobility deficits, they're likely going to be between 40 and 65 years old. That's not always true. They will probably have a progressive worsening of pain and symptoms, passive range motion limitations in multiple directions, especially external rotation. And then they're going to have limited joint accessory motion. This person, they can have like a shoulder stiffness, but this person also, this category fits closely with adhesive capsulitis. Next, shoulder instability. We typically see instability in younger people, so people under 40. These people probably have had a history of dislocations. They have excessive glenohumeral joint motion. So whereas with mobility deficits, you obviously have a lack of motion, instability is excessive motion. And then they're going to have apprehension at end ranges of flexion, horizontal abduction, and external rotation. So with this, they have instability. We're likely thinking that there's a problem in the joint stability. We're also thinking that something with the superior, middle, or inferior glenohumeral ligaments is not checking those motions. And then lastly, we have rotator cuff dysfunction. So the 4 rotator cuff muscles, if those aren't giving enough stability or muscle power to the shoulder, then we're going to see, a whole collection of signs and symptoms because of that. That can be impingement signs. It can be their resisted motion testing might be painful or weak. We're going to see rotator cuff muscle weakness. So even though we're calling it rotator cuff dysfunction, it can be sort of any muscle power dysfunction in the glenohumeral joint. And then the other category is going to be things like a fracture, which we treat, but it doesn't really fall under the first three. AC joint injuries, arthritis, neural tension, so maybe like a thoracic outlet neural tension, and then chronic pain, post-operative pains. On the tissue irritability, I want you to look through these on your own, but this is going to, let's say someone comes in with a 7 out of 10 pain, that's going to be a different plan of care or a different point in their plan of care versus someone who has low pain or low. So if someone has 3 out of 10 pain, we can likely do way more active range of motion and higher functional demand versus when they come in flared up, they still have the same diagnoses. They're just at a different point in their rehab. So that is how you should approach an evaluation. We need to see if they're appropriate for PT. We need to find the origin of symptoms, and then we need to use our tissue irritability to determine how to treat. Next, we're going to get into some differential diagnosis and examination using the principles of anatomy and using the principles of the evaluation that we just talked about. So similar to how we talked about the case study at the very beginning of the lecture, let's talk about some potential causes of anterior superior shoulder pain, just from a differential diagnosis standpoint. So the person, if they come in and they have pain anteriorly and superiorly, we could think that it's subacromial impingement syndrome. It could be a rotator cuff tear. It could be an AC joint pain, so number 4 on this. It could be something to do with the collarbone, so a clavicular fracture. It could be bursitis. There's a number of things, and we need to think about what are the different bony tissues and soft tissues or potential nervous system things that go through that area that could contribute to anterior superior shoulder pain. Well, the most common thing that we see with people is going to be subacromial impingement syndrome. And so impingement syndrome is the most commonly referred diagnosis for shoulder dysfunction, and it's due to the repeated or persistent compression of the structures in the subacromial space. So as one lifts their arm overhead, and as the humerus is trying to get through that full range of motion, if the acromion gets in the way, there's going to be decreased space there, and that's going to cause a pinching or compression type of pain. Clinically, we see this with an excessive anterior scapular tilt or excessive scapular internal rotation, and often associated with abnormal scapulohumeral rhythm. And this makes a lot of sense. If someone comes in and if their shoulders are getting pulled forward this way or too much rounded internally, that chronic position is going to limit the ability for the humerus to get into the proper position. Now, as you can see, the position of the rib cage and the thoracic spine is really important for what happens at the glenohumeral joint. So we need to be considering the regional structures as we're dealing with shoulder issues. The bullet point here says patients with impingement syndrome have shown decreased levels of serratus anterior activity, a delay in the firing of the middle and lower trapezius, and dominance in the upper trap. And that matches what we were talking about in the anatomy section earlier. There are a few different types of impingement syndrome. There's primary, secondary, and posterior. Primary impingement, how the shoulder is getting impinged or what's the cause of it, and then where it's happening are sort of how we delineate these things. So with primary impingement, it's a direct result of compression of the rotator cuff tendons between the humeral head and the anterior third of the acromion or the coracoacromial ligament or the coracoid itself. So the architecture or the setup of the acromion plays a significant role in primary impingement. There's going to be peak compressive forces between 85 and 136 degrees. And that's why the painful arc test is one of the 3 sort of diagnostic criteria for primary impingement. The 3 tests that we're looking at for primary impingement are going to be a positive Hawkins-Kennedy, where you take the arm into some flexion and internal rotation, and then give overpressure there. And if that causes pain in the shoulder, that's a positive test for primary impingement. That test doesn't have very good diagnostic accuracy. The other test is the painful arc test, where if you have pain between roughly 60 and 120 degrees of shoulder flexion, that's a sign that there's a decreased space in the subacromial and there's impingement occurring, and it's another positive test for primary impingement. Now, to that point, it doesn't necessarily indicate that the person, because the diagnostic criteria of those two are not the best. I mean, what we're seeing is going to be they may or they may not have it still. The test with the best diagnostic accuracy is the infraspinatus muscle test. And so that's your resisting shoulder external rotation. And that has a positive likelihood ratio of 10.56 and then a negative likelihood ratio of 0.17. So we can kind of, what's tricky is that the person might have impingement, or if that test is positive, they might have some rotator cuff pathology. And impingement is a diagnosis, but it doesn't tell us exactly the underlying cause of that. So someone can have primary impingement, but that could be due to a rotator cuff issue, or it could be due to some underlying instability. There's a picture here of the 3 different types of acromions, and types 2 and 3 are going to be more likely to have impingement because of, you can imagine if you have a hooked shape of the acromion, and then as you try to raise your arm up, you're going to be hitting that undersurface, or there's less space available in the subacromial space. Neer created a classification for subacromial impingement syndrome. In stage 1, you're going to see edema and hemorrhage. These are usually in younger people, and it's often reversible with conservative treatment. If that progresses into stage 2, that's where we're going to see fibrosis and tendinopathy. So an overuse of those structures that are getting pinched in the space. This occurs as someone gets slightly older, and 25 to 40 years old. They're going to be having recurrent pain. They may or may not do well with physical therapy. And at that point, you may consider a subacromial decompression. And then in stage 3, this is the chronic state of it, where they're going to have bone spurs, that tendinopathy has then turned into a tendon rupture, and we're going to see progressive disability at this point. Next is going to be secondary impingement. So whereas before this was because of a direct result of compression between the humeral head and the acromion, secondary impingement is due to underlying instability of the glenohumeral joint, and that's often associated with anterior instability. These people are going to be younger when they come in, and they probably have a history of instability, so a history of subluxation or dislocation. It's more common in overhead athletes, and they're going to have pain with overhead activities, and we're going to see probably a global hypermobility or laxity. These people have scapular weakness and scapular dyskinesia. They may or may not have some of those primary impingement syndrome positive tests. So, it's based on their level of irritability. They may have a positive painful arc, or they may have a positive Hawkins-Kennedy. But the bigger things that you're looking for are scapular weakness and scapular dyskinesia. The third and final type is posterior impingement, and that is undersurface impingement. So patients are going to have posterior pain in a 90-90 position. So here and here, as you go back into that position, the supraspinatus and infraspinatus rotate back, and that twisting action creates a pinch on the backside of the shoulder through here. It creates friction or rubbing along the posterior surface of the glenoid rim. And additionally, we were talking about force couples earlier. The person who has a really dominant posterior deltoid can often develop some of this posterior impingement if the supraspinatus and infraspinatus aren't locking or holding the glenohumeral joint into position. These 3 types of impingement can be tricky. I want you to know that oftentimes people will come in with a diagnosis of impingement, and then we need to determine what the underlying tissue structure that is causing that impingement. One of those common causes could be a tear, tendonitis, tendinopathy of the rotator cuff. So a rotator cuff tear is going to be any loss of tensile strength in the rotator cuff muscles, any of the 4 of them or multiple ones at the same time. This can be due to a repeated sort of micro trauma, someone who has had impingement syndrome for a long time and has repeatedly created friction across the rotator cuff, or it can be due to a single micro trauma where someone picks up something heavy and they're not strong and stable in their shoulder position, and that causes a tear of the rotator cuff. Tears can be partial or full thickness. We see these on MRIs all the time, where someone comes in with pain in their shoulder. They have some imaging done and it shows tendinosis, so a chronic tendinopathy of the shoulder, chronic tendinitis of the shoulder, and that has then led to some partial tearing in the rotator cuff muscles. And we're like, as I just mentioned there, we're so tendinopathy and the partial or full tearing are going to be common findings that we're seeing. With rotator cuff tears, MRI and ultrasound have shown that between 13 and 34% of asymptomatic subjects have rotator cuff tears. So that means that some people who don't even know that they have a rotator cuff tear are going to be coming into the clinic, or they won't be coming into the clinic because they're not having pain at that point. But it says that the reliability of MRIs and ultrasounds are not always the greatest for a predictor of pain. Asymptomatic people with rotator cuff tears have a 51 chance of becoming symptomatic. Okay. Partial thickness tears usually progress to full thickness. Are there things that we can do about that? I think by proper strengthening and good posture and alignment of the body and stuff, we can prevent those partial thickness tears from becoming full thickness. And full thickness tears do not heal. So roughly 33 to 90%, so a huge range, have reported improved pain and function with full thickness tears. So typically I would say if someone has partial thickness, there's a ton that we can do for physical therapy. When they come in with a full thickness tear, our chances of success go down. It doesn't mean that it can't be done, but then we need to be considering one's individual lifestyle and goals before we talk about surgical options. But typically the full thickness tears are going to go in for surgery, much more common than someone with just a partial tear or tendinosis. Full thickness rotator cuff tears require surgical treatment and subsequent aggressive rehab to achieve a positive functional outcome. And as you know, treating rotator cuff tears post-surgically is very challenging. There's a lot of pain associated with it. There's a period, usually 6 to 8 weeks of just like passive range of motion into active and active assisted range of motion. And then capsular laxity and labral insufficiency are going to create greater stress on the rotator cuff muscles. So in addition to the things like subacromial impingement, when someone comes in and they have capsular laxity or they have an issue with the labrum of the shoulder, that's going to put a greater chance that the rotator cuff's going to have to work harder for stability, increasing the chance of injury to those muscles. When someone comes in with a rotator cuff tear, we need to assess their passive and active range of motion because we need to see if it's a muscle power deficit problem. So someone who has a rotator cuff tear will likely lack active range of motion because, so let's say they go through the active range of motion and it's lacking, but then that person's going to have significantly or probably full passive range of motion. We need to test so we need to do different rotator cuff strength testing, and we need to evaluate their scapula. So is the rotator cuff being placed on significantly more stress and strain because the position of the scapula isn't allowing it to set against the spine? For different imaging, we're commonly going to see MRIs as the gold standard, or MR arthrography as the common kind of gold standards for rotator cuff tears, but we'll also see diagnostic ultrasound. The MRI and the MR arthrography are much considered the gold standard versus the ultrasound. Testing, this is going to be similar to what we're going to see from our subacromial impingement testing, but then also we're going to be teasing out the specific rotator cuff tear testing to see if that person has the severity of the rotator cuff tear. With the external rotation weakness sign, what you'll see here is if someone, as you bring their arm out to the side, if they can't hold that position, it'll literally slowly work it fall back back towards the body. So they're unable to hold external rotation. Drop arm sign will be the same thing. If someone holds their arm there, it might not be that their arm drops immediately, but what you'll see is trying to hold the arm there, that this sort of thing happens. So they start using their trap and their deltoid and their levator to hold the arm up versus the ability for the rotator cuff to stabilize that position. The manual muscle testing for rotator cuff tears have significantly better diagnostic accuracy than some of the impingement tests. When we're doing a active range of motion assessment of humeral internal rotation should include scapular stabilization. Internal rotation loss is often associated with posterior capsule tightness, and it can lead to anterior shear of the humerus, which will impact the rotator cuff and the bicep tendon. What I mean by it should include scapular stabilization is sometimes when people assess internal rotation, as you're going into it, we let the scapula sort of dump with that movement. So you'll see an anterior tilt of the scapula. We need to assess this from a position of staying strong there and not letting it tip forward. Anterior translation of the humerus and superior migration are two key factors indicated in rotator cuff injury. And so as we're assessing for rotator cuff, we also need to assess for capsular tightness of the glenohumeral joint. And as we talked about earlier, as we're trying to do a differential diagnosis of rotator cuff tear versus capsulitis, we're looking for the pattern of external rotation being more limited than abduction, being more limited than internal rotation. And that's our capsular pattern. So ER is more limited than abduction, more limited than internal rotation. The rotator cuff manual muscle testing. To test for the supraspinatus, we're going to put the arm in 30 degrees of abduction, slight external rotation, and then 30 degrees of flexion as well. So as we're here, we're gonna assess the strength and the function of how well you can hold the shoulder in that position. For the infraspinatus test, 0 degrees of elevation with 45 degrees of internal rotation. So you put them there, and then we assess how strong the body is against external rotation resistance. The test for the teres minor is called the Pate test, and then for the subscapularis, it's the Gerber liftoff position. So that's internal rotation behind the back. Can they lift their arm away here? These are very common tests. Most PTs know how to do these. What I would look at the most is review the specific diagnostic criteria for each of these. We talked about being stabilizing through the scapula a minute ago, and the test that's used for that is called the Kibler's subtle scapular dysfunction test. And what we're looking at is the position of the inferior angle, the medial border, and the superior scapular angle. And this is a purely observational test. I find that because they're observational tests, the diagnostic criteria gets tricky, and there's a lot of inter and intra-related reliability issues. I think being able to evaluate the position of the scapula and being able to hold a scapular position is very important for how well or how much stress and strain goes across the rotator cuff and goes across the labrum and the capsular tissues. So as these tests are important to do clinically, you're not going to see the best diagnostic accuracy or reliability as we're talking about it from an OCS standpoint. The clinical cluster that you need to know for the rotator cuff is, and this is for the presence of a full thickness rotator cuff tear. So full thickness rotator cuff tear, we're going to see a positive drop arm sign, positive painful arc sign, and then weakness with the infraspinatus manual muscle testing or a shoulder external rotation leg sign. The 2008 Park study concluded that if all three tests were positive, the probability of a patient having a full thickness tear was 91%. So if all three of those are positive, that's going to be a pretty good likelihood that they have a rotator cuff tear. Now, what's tricky is if all three of these are positive, I think it's kind of obvious they have a rotator cuff tear, because if they have an inability to hold a muscle position, like if you can't hold your arm in one position, or if you're doing a drop arm sign and there's significant compensation, those are obvious things that something's going on. So it's almost not surprising that the diagnostic criteria is much better on these three tests. There's a clinical prediction rule for the diagnosis of rotator cuff tears as well. And that's going to be the weakness of external rotation. So that external rotation leg sign. And then the other two criteria that this study found was that individuals over 65 that's going to increase your likelihood or be a high predictive variable. And then also the presence of night pain is very important. I think, if you do an MRI on a number of people over 65, it's probably going to show some rotator cuff dysfunction in general. So you need to know this from a CPR OCS exam standpoint. But again, these are common, like almost common sense. And it's tricky because a lot of people with shoulder pain will complain of pain in the evening time or pain at night when sleeping or rolling over. So the the most important variables of this one are the age and the weakness on external rotation. So I would know this for the exam because there's a pretty good positive likelihood ratio. So if you have 4 or more total points, that's a positive likelihood ratio of 9.8, which is clinically significant. But if you think about this logically, that makes a ton of sense. Like, okay, we're seeing a gross amount of weakness on external rotation. It's an older person who's having shoulder pain and pain sleeping at night. The next thing from a differential diagnosis standpoint is going to be bicep tendon pathology. And these people are going to present with pain over the anterior aspect of the shoulder, kind of in that bicipital groove. It's going to be tender to palpation over the biceps tendon. If someone's pretty rounded through their shoulders, they're going to have pain there either way. So be kind of cautious about the using palpation as a diagnostic criteria. These people are often going to have clicking and popping in the anterior shoulder. And then if the tendon retracts, you're going to see the Popeye deformity. And what that means is that if there's too much strain across the bicep tendon and it actually ruptures, that thing is going to coil down, and then the bicep's going to be really low in the arm versus sort of the full length of it. You'll see that muscle shift down to the lower edge. Once you've seen a few of them, the Popeye deformity becomes very obvious. Sometimes the person still feels like they won't even know that they have the Popeye deformity because it just looks like their muscle has gotten slightly smaller, but it is distinctly lowered in the lower half of the humerus. Treatment for this is going to be physical therapy, NSAIDs, injections, and a percentage of people will have surgery. But surgery for proximal bicep tendon pathology is much less common, surprisingly. This is a picture of the bicep deformity here. I mean, this is a pretty obvious one, but you can still see they can make the bicep, but because it doesn't connect all the way up into the labrum, so where the bicep tendon attaches into the glenoid ligament here, what you'll see is it retracts down. So then it's a much shorter lever arm, and the muscle belly is going to be lower on the humerus. The bicep does play an important role in shoulder stability. It acts as an anterior shoulder stabilizer. If torn, we're going to see decreased elbow flexion, decreased supination, and decreased shoulder abduction strength. The reason is, so we know the bicep, like you can see the bicep turns on with supination. It obviously is a flexor of the shoulder and the elbow, and because of its position, it contributes to shoulder abduction as well. It plays a significant role in anterior shoulder stability, but take that with a grain of salt because a lot of people will do just fine after their bicep tendon retracts, so it is lower in the humerus. They'll still do very well. 90+% of people do fine having that bicep tendon retracted. Some people will wake up and they don't even know that it happened. It's an atraumatic injury in many people. The different testing that we can do are the O'Brien's active compression test, bicipital load test, the speeds test, and resisted supination external rotation. None of these tests exhibit good diagnostic accuracy. So from an OCS exam standpoint, you should know that these are different options for testing the bicep tendon, but none of them, especially individually, are gonna be too accurate because of the crossover of other things that we're assessing during these tests. Meaning a lot of other structures are getting stressed and strained as we're assessing bicep tendon pathology. So we talked about how the proximal bicep attaches into the labrum. So the next thing we're going to go over is labral tears. And when someone comes in, well, first of all, you can see the special tests here are very similar to the bicep tendon testing. Here we have an O'Brien's active compression test, the bicep load 2, that's supination external rotation test again, and then the crank and the clunk test. Those are the two other ones that we can add in here. Again, not the best diagnostic accuracy on these testing. So from a true understanding, we need to rely on imaging, like an MRI. But what's tricky is that then how significant is that MRI to your plan of care? And then that's going to be a variable question. So we need to use our evaluation and examination testing. For a labral tear, we need to assess the range of motion of the person. We need to see, so where is their range of motion limited? Where is their strength limited? What is the stability of the glenohumeral joint? Because the labrum has a stabilizing, that's its primary function, is to act as a stabilizer of the shoulder. So we need to see if any of that is getting compromised, which is going to then direct, are we doing a conservative plan of care versus surgical? The most common labral tear is a slap lesion, and that's a superior labral detachment from anterior to posterior. So slap, superior labral, anterior to posterior. With this, the long head of the bicep tendon is often involved, and that's because of its intimate connection to the labrum. This tear is often between 2 o'clock or 10 o'clock and 2 o'clock if you're looking at the position of the labrum on the shoulder from the side, so between 10 and 2, and it significantly increases the strain on the anterior band of the inferior glenohumeral ligament. So if you have a slap tear as someone goes into a shoulder, like a throwing position, because the labrum isn't stabilizing as much, then the ligament, the inferior glenohumeral ligament, is going to take on more strain in that position. Slap tears are thought to occur due to a peel back mechanism, which is maximal shoulder external rotation is thought to, as you go into that position aggressively, it's thought to peel back the posterior labrum. And then an MR arthrogram or MR contrast MRI are the most sensitive and specific for diagnosing slap tears. That's an important OCS key point there, is that MRI arthrogram or contrast MRIs are the most sensitive and specific for diagnosing slap tears. There's a few different type of slap tears that get progressively worse as you go from type 1 to type 4. I'm going to have you read over those on your own, but just know that there's 4 types of slap tears that are going to be of interest to you clinically, because that's going to determine their likelihood to succeed with conservative versus surgical management. We talked about that, the testing that is sort of carryover testing between the bicep tendon and the labrum. The 2 other tests that I mentioned were the crank test and the clunk test. And with these tests, again, they don't have the best diagnostic accuracy. So I want you to read over how to do these tests, because they're important to look at as a clustering to see if someone has pathology in their labrum. But again, you need to use the range of motion, the strength testing, your glenohumeral mobility assessment to determine if you think they have a labral tear. Oftentimes, a repeated popping in the shoulder or a clunking sensation in the shoulder can be an indication that someone has a labral tear. And you'll see from like what we're looking for with both of these tests is going to be symptom reproduction or crepitus in the shoulder for the crank test. For the clunk test, we're looking for, as we reproduce their symptoms, we're looking to see if we can get this clunking sound or sensation in the shoulder. And if you do that, it says that we're working over that torn part of the labrum, and that's causing some derangement intra-articularly, meaning something's wrong. And so we're hearing that and feeling that with these manual therapy tests. Next thing is acromioclavicular joint dysfunction. Approximately 40% of sport-related injury shoulders involve the AC joint. So if the person comes in and they told you they had this, they're having anterior superior shoulder pain after some sort of sport injury, an AC joint problem is going to go up higher on your list right away, especially if there's some sort of trauma involved with it. Diagnosis of AC joint injuries is made clinically and with radiographic imaging. Another important OCS fact is that the Stryker notch view can rule out a coracoid process fracture. So the Stryker notch view is going to be important for a few different shoulder things. The classification for AC joint dysfunction is called the Rockwood classification, and there's 6 different types of injuries that can occur at the AC joint. With a type 1, you see that there's just ligament stretching at the AC joint. Type 2 is going to be a partial tear of the AC ligaments. 3 is going to be both the AC and the corticoclavicular ligaments are ruptured. And then you see it gets progressively worse in 4, 5, and 6. Type 6 is very rare because the clavicle is actually pushed underneath the coracoid, and that could be a more dangerous situation. With these, you can imagine the mechanism of injury as if someone gets hit or they land on their shoulder, it pushes the humerus down or that side of the joint downward, and then so it leaves this to sort of restrain that injury. So this gets pulled down as the shoulder's up here still. Type 6 would be the opposite mechanism of injury, which would be so the arm gets pushed up forcefully at a rate where this is getting decompressed or getting compressed. So a type 6 is pretty rare. Types 1 through 3 need to be conservatively managed, or they do well with conservative management. A lack of evidence exists to support surgical treatment for type 3. So 1 and 2, conservative all the way. Type 3 still is conservative. Some people, at that point, you're kind of going back and forth, but just know that there's a lack of surgical evidence even at that level, type 3. 4, 5, and 6 are going to, because of the degree of instability and the degree of ligament tearing, we're going to see that surgical management is required. Post-operatively, the person's going to be in a sling for 6 to 8 weeks, and then we need to be cautious with active assisted range of motion for horizontal adduction and internal rotation behind the back as well. And because those positions, we talked about the arthrokinematics, as the arm goes up, we need that posterior rotation to occur in the shoulder joint. And as for surgical reconstruction, as those ligaments are healing, we need to be cautious with our return to range of motion. One's pain, if they have a fairly normal tolerance of pain, that will help guide you in that 6 to 8 weeks of how much we can push. So we've covered rotator shoulder subacromial impingement, rotator cuff tears, bicep, labrum, AC joint. Now we're getting into shoulder instability. And this means dislocations or subluxations of the shoulder, like true instability, not just weakness and laxity in the muscles, but instability of the shoulder. Most shoulder dislocations occur in the anterior direction with the arm abducted and externally rotated. What that means is as you go into abduction and external rotation, the anterior structures here, the shoulder is getting pushed forward that way, so it dislocates anteriorly. It's a combination of the balancing of the forces around the shoulder. So as one goes into that position, the posterior cuff needs to be able to pull you there, and the anterior, so that then doesn't put excessive stress and strain across the anterior structures. With shoulder instability, there's risk of the nerves in the area to be let's say you could have a peripheral nerve injury with shoulder instability, and the axillary nerve is the most commonly injured nerve following a shoulder dislocation, and that can happen in up to 30% of dislocations. So when someone comes in and they've had some shoulder instability event, you need to be looking for muscle weakness, and then you need to be asking for numbness, tingling, are you feeling vague pains down the arm, that sort of thing. And then atraumatic multidirectional instability is a common cause of dislocations. So that's a loss of stability in more than one direction. As we get it, we're in the next slide, we're going to talk about TUBS versus ambry. So TUBS is going to be a traumatic unilateral. Ambry is this multidirectional instability. This is often due to a redundant or torn joint capsule or a laxity in the ligamentous structures. So if someone goes into this position and these structures here are weak or lax, there's going to be a much higher tendency for the shoulder to push forward. The things that we're looking for in shoulder instability are going to be a visibly deformed shoulder, so that positive sulcus sign. They're going to have swelling or bruising. They could have intense pain. I mean, if by the time we're seeing them in the orthopedic setting, that shoulder will have been reduced. So like they're probably just going to have pain and the sensation of instability or weakness in the arm, fear and guarding around movement. And that's because these structures have just been stressed to sort of their end limit. And then because of that, there's going to be an inflammation, pain guarding response that follows. And we need to respect that. We need to strengthen things and let things sort of tighten and heal back up as we go through the rehab process. With shoulder instability, we need to look at neurofunction, and we need to palpate the pulses to make sure there was no vascular compromise. The testing that we're looking for is the apprehension and relocation test. So that's when someone's on their back and you bring them in this position. If that's apprehensive, that's a positive sign that something that the anterior shoulder is not restraining that position. Relocation would be if you're here and then you hold that position and it feels significantly better to give pressure to the anterior shoulder. The sulcus sign is when someone pulls the arm down and you can see a large gap between the acromion and then where you pulled the humeral head. And then you want to do your mobility testing as well. This picture shows you sort of the close approximation of the radial nerve and the axillary nerve, which are two of the common nerves involved in shoulder instability. As I mentioned a few slides back, the shoulder instability can be due to, what we say is the acronym TUBS or AMBRI. TUBS is going to be a traumatic unilateral in the anterior direction dislocation. They often have a Bankart lesion, and then these people require surgery. There's a low non-operative success rate for these. So this is the person who has not had dislocations before, but traumatically that shoulder gets pushed anteriorly and dislocates. So it just happens in one direction at one time. They have a Bankart lesion and it requires surgery. AMBRI is the other population of people who have shoulder instability events. These are atraumatic. So this person might just dislocate as they are doing something, doing something normal around the day. They have instability and weakness in multiple directions. These people, because this is almost like these people might be hyperlax, or they might have a connective tissue type of problem. They dislocate bilaterally. It's not a one-off event for these individuals. These people also do have a much higher success rate with non-operative management. If they do have surgery, so the AMBRI, the I component is going to be an inferior capsular shift, meaning a tightening of the capsular tissue to try to snug up the position of the shoulder. A Bankart lesion is found in 80. So let's go back to the TUBS. The B here is for Bankart lesion. And that is going to be a Bankart lesion is a labral detachment from 2 to 6 p.m. on the right shoulder or 6 to 10 p.m. on the left shoulder. This occurs in those traumatic dislocations in 85% of people. So if you have it, and that's why surgery is often required to tighten the shoulder back up. It's going to happen in an anterior inferior detachment, which decreases the stability of the glenohumeral joint, and this can lead to recurrent instability. So someone who has a traumatic unilateral injury, they're likely to have a Bankart lesion, and they're also likely to have what's known as a Hill-Sachs lesion, which commonly occurs during the Bankart. So like think about it as traumatic instability, they have a Bankart, and they're likely to have a Hill-Sachs lesion as well. The Hill-Sachs lesion is a compression fracture of the posterior lateral aspect of the humeral head. Because it's traumatic, there's a significant amount of force that goes across the glenoid labrum. And as it gets pushed into that position, the posterior lateral aspect of the humeral head takes on a significant amount of pressure. And then you can have a fracture there known as this Hill-Sachs lesion. We talked about the Stryker notch view earlier. And this is important for the OCS, the best viewed radiographic measure is using a Stryker notch view to look for this Hill-Sachs lesion. So TUBS injury, Bankart, Hill-Sachs. The true incidence of Hill-Sachs is unknown, but it's suspected that it occurs in 40 to 90% of anterior shoulder dislocations. There is also a reverse Hill-Sachs, which is a compression fracture on the anterior medial humeral head from a posterior dislocation. So if a Hill-Sachs happens as it's an anterior location, the reverse Hill-Sachs is the complete opposite, and that's going to be from a posterior dislocation. I mentioned the apprehension test, and then also people who have shoulder instability, especially those people who are in that Ambry classification. So it's atraumatic multidirectional. Those individuals you might want to do a Beighton rule of nines on, which just shows that they have gross hypermobility or hyperlaxity throughout their body. There's over 250 shoulder stabilization surgeries, and that seems like a crazy amount. For the Ambry people who are not having surgery, we need to exhaust conservative management. If conservative management is failing, then we need to do that inferior capsular shift, which is a common surgery. Bankart repair is the gold standard for treating anterior instability. That's very important. I'm going to say that again. So there's a ton of shoulder stabilization surgeries that can be done, but Bankart repair surgeries is the gold standard for treating anterior instability. One's exercise progression is going to be dependent on specific surgical procedures. With shoulder instability, we talked about the different surgical options. In the current concepts, they talk about a repair for the capsular plication. These people should expect full range of motion. Use this as an example of shoulder instability protocol. They should expect full range of motion in 10 to 12 weeks. Unlike a rotator cuff tear where we want to see full range of motion before that, with a capsular plication, we need to go a little bit slower. So we're not going to see full range here for 10 to 12 weeks. And we need to be cautious to avoid excessive range of motion early on. These individuals, they're lax already, like their baseline is laxity. So we need to go slow and not aggressive in the early phase to let their tissues stiffen up so that we need to slowly work into that range. My bullet point at the bottom is for surgical instability protocols, I would recommend reviewing the current concepts that sort of outlines kind of the exercise progression for this. And then adhesive capsulitis is next on our differential diagnosis list. Frozen shoulder, it occurs in 2 to 5% of the population. These people are typically 40 to 65 years old. Females more commonly than males. We don't really know why that's the case. Potentially a hormonal reason, but there's a higher incidence of adhesive capsulitis in individuals with diabetes or thyroid disorder as well. And X-ray is considered to be the standard of practice and often a good first choice. If you're suspecting adhesive capsulitis, you can do an X-ray to help rule out other things such as osteoarthritis of the shoulder. From the current concepts, you should know that a range of motion loss greater than 25% in at least 2 planes and passive external rotation loss that's greater than 50% of the uninvolved shoulder or less than 30% of external rotation has been used to define adhesive capsulitis. I would reread that 2 or 3 times or look at the current concepts to make sure that you understand what true adhesive capsulitis is. Another key OCS point is this hallmark finding for a clinical diagnosis. And so that's what we just talked about, it limited passive external rotation of 50% or less than 30 degrees of external rotation with the arm at the side. So if you're checking it here, if I have less than 30 degrees there, that's a hallmark finding for shoulder external rotation. Or if I can go to 60 plus, and then I can only go a little bit. So if I'm all the way out here and I can only get to here, that's a hallmark sign for a clinical diagnosis. Research has shown that posterior MOBs have greater effectiveness than anterior MOBs for patients with adhesive capsulitis. I mention that because you would think that if one's lacking external rotation from a MOB standpoint, you'd want to be doing an anterior mobilization if we're talking about the arthrokinematics. But because of tightness in the posterior capsule, we need to normalize the posterior capsule range with posterior mobilizations that has shown to be more effective than mobilizing the shoulder anteriorly. I personally don't do any anterior shoulder mobs. I do a lot of mobility across the anterior shoulder through stretching the soft tissue, but from a very connected sort of way. I do very little, just self like mobilizations to the anterior shoulder. Rehab for people with adhesive capsulitis. Successful treatment should not be dictated by a full return to normal rotation, and that's because it can take a long time for individuals to get back. So, if we can get them back to a baseline level of function, that's considered successful. I personally try to strive for a little bit more than that, but that's sort of what the research is telling us. 89.5% of patients responded with non-operative management when with adhesive capsulitis, and that was with a combination of PT and non-steroidal anti-inflammatories, and then one or more corticosteroid injections. There is a strong evidence for supporting the use of corticosteroid injections plus exercise to improve pain and function in patients with adhesive capsulitis in the first 3 to 6 weeks. A few key points there. One, corticosteroid injection and exercise. So the combined approach of those, and that's going to be early in the rehab process. So like when they're more in that inflammatory state, if you can get a corticosteroid injection with exercise early on, that's shown to have the best evidence. Other bullet points on the rehab of this is performing stretching and joint mobilizations to improve shoulder external rotation has been effective. And then we need to be considering the intensity, frequency, and duration. Those should all be used when dosing our stretching interventions. We talked about high irritability, middle and low irritability. So greater than 7 out of 10, 3 to 7, or less than 3 out of 10 on their pain scale. We need to use that at pain scale to determine how aggressively to stretch someone. If they're coming in with a fairly high level of pain and you're doing end range mobilizations, that's going to piss off that tissue more, create more inflammation, and then set us back. So if they're having high 7 out of 10 or more pain, we need to do low grade mobilizations. If conservative management fails, there's the option for a manipulation under anesthesia or a capsular release, but the manipulation under anesthesia, they take you into that, under anesthesia, they adjust your arm all the way back. And while it does improve range of motion slightly, that's also been shown to cause other problems in the shoulder because you're sort of ripping through tissue to get range of motion. I do not elect for people to get the manipulation under anesthesia. I just think there's better options that can be done because that person probably needs to be doing more at home realistically. This is something we talked about earlier, but it just reviews the tissue irritability scale for dealing with individuals with adhesive capsulitis. And then a few other notable points of information. So the corticosteroid injection, we talked about that 3 to 6 or 4 to 6 weeks is what it says here that has grade A evidence. There's also grade A evidence to use functional outcome measures such as the DASH, the ACEs, or the SPADI. And then patient education has pretty good evidence as well, a grade B evidence. And then that translational manipulation under anesthesia has weak or mixed evidence. So that sort of confirms what I was just talking about. Other things that we'll see less commonly in the shoulder is osteonecrosis, so bone death or avascular necrosis of the humeral head. If you're going to see this, it's going to be most common after fractures or some systemic corticosteroid use or a thyroid issue or significant heavy alcohol use. That's when you're going to see osteonecrosis of the shoulder or other joints for that matter. And then lastly, we're going to just briefly talk on rotator cuff tears, operative and non-operative management. So with rotator cuff tears, the non-operative management, we're going to see an initial management is going to be protecting it from outside stress. So we need to not function, meaning if we're seeing someone with a rotator cuff tear and they have not had surgery, we need to gradually get them back to function. So we need to protect them in ranges that aren't going to take a partial tear to a full tear, but we need to be working on that gradual exposure back to function. Early in one's non-operative plan of care, submaximal isometrics are beneficial. So strength isometrics, we're strengthening or engaging that rotator cuff muscle just in one position. So we're not taking them through large range of motion. We're just stabilizing one position and getting blood flow to the muscle. Additionally, I've talked several times about the importance of scapular stability. So we need to promote the force couple between the low trap and the serratus to help support the scapular position, which is going to dictate and support the rotator cuff muscles. And then we need to be addressing range of motion deficits that might occur from a loss of mobility due to the loss of muscle power. Job strengthening exercises are common PT exercises that we can be doing to help promote rotator cuff strength and function. And then the ACEs, the ROW, and the UCLA tests are all good outcome measures for the athletic population. When we talk about operative management, we're seeing repairs are becoming increasingly common, and this has a huge economic cost on the world and in the United States. Now more than 95% of these are arthroscopic. Before there used to be these full open procedures, which were much bigger and long. They used to cut through more muscles. Fortunately, now everything is arthroscopically done. So small incision holes with minimal other tissue damage. There's so many factors that can impact the rehab, and those are going to be the timing of one's repair, the patient's character, like so the patient's individual demographics of the person, this person's access to care, surgical's philosophy on the rehab following treatment, the surgical approach that's used, the size of the tear and the tissue quality are hugely important when we're wondering about how well someone's going to do after surgery. So if they have a small tear, that's going to be a much different approach than if someone comes in with a large or a massive sized tear. That's going to require more protection after surgery to make sure that that muscle can heal and it can integrate back into the body. Other factors that impact healing afterwards are going to be the person's age, the tear size, the tissue quality, other lifestyle habits such as smoking or diabetes or other comorbidities. There's a whole bunch of things that you should know that can impact how well someone can heal after a rotator cuff repair. When you're wondering if should you do an accelerated approach or a slower approach, the factors that you should consider are what we talked about prior is the chronicity of the tear, the tissue quality of the patient, which will be determined by their lifestyle and their age, the ability to meet different staged goals. So if they are more committed to their rehab or if other things are allowing for that rehab to be successful, and then their tolerance to rehab stresses. So if they have a good baseline level of strength, that might put them at a higher tolerance to be successful with rehab. The best environment for healing is immobilization and limited passive range of motion during the first 6 weeks. And then, what I typically say is in the first 6 weeks, we need to do passive range of motion to the point of pain. And at 6 weeks and on, then that's where we get into active range of motion at 8 weeks, or active assisted range of motion. And then at 8 weeks, active range of motion. Immobilization or early passive range of motion. A systematic review found insufficient evidence to promote an evidence-based conclusion or recommendation regarding immobilization versus early passive range of motion. That means that it's okay to do early passive range of motion for people. Just immobilizing for 6 weeks is not better than early passive range of motion. Early on, you want to perform passive range of motion in the scapular plane. There's the sagittal plane passive range of motion increases stress across the supraspinatus tendon. So if I'm doing range of motion here, there's going to be more stress on the supraspinatus versus if we follow the anatomical alignment and work on passive range of motion in that scapular plane. Depending on surgical factors, we're going to begin active assistive range of motion or supportive range of motion between 3 and 8 weeks. I typically see with protocols that it's usually at that 6 weeks is that we go with active assistive. But somewhere in that time frame is where we're moving from passive to active assistive range of motion. Just a note to be cautious with the pulleys for Therax because those have been shown to use significant muscle activation. The Codman's pendulums have minimal rotator cuff activation and are more, and they're more true passive range of motion. They're not truly passive range of motion, but there's minimal rotator cuff activation. This is an example for a standard rotator cuff protocol for a medium-sized tear. We said passive range of motion for 6 weeks. We progress from passive to active from between 6 to 8 weeks. And then at 8 weeks, we typically initiate the isotonic strengthening. We begin with light weights and bands at 10 weeks, and then we can initiate a prone shoulder external rotation around that same time, 10 weeks as well. The goal is at about 4 months post-surgically, we should be preparing for discharge. So between that 10 and 16 week marker where we're gradually progressing strength, that'll turn into more functional testing. We're planning like for a home PT program after 4 months. The last section here is on different shoulder imaging. I'm going to have you read over these versus me just talk about them. There's usually 1 or 2 questions on specific shoulder imaging, and that's reserved for what you should know is that specific differential diagnoses have specific series or images that should be done for them. Okay, that was a ton of information. If you have questions on this lecture that I recorded here on the Optum OCS Facebook group, you can post them on there. You can reach out to us through email as well. But I hope that gave you a good overview of the anatomy, differential diagnosis, evaluation, examination, and then some post-surgical considerations to take. So thank you for listening and have a good day.